Welcome to today's episode of Ignite Health, brought to you in partnership with Caribbean Surgery Inc. This program is dedicated to empowering you, our wonderful audience, with trusted medical information, expert insights, and a practical guide to help you take control of your health. I'm Dr. Surendra Prasad, the Medical Director at Caribbean Surgery, and your host for today. Each week, we break down important health topics, answer your common questions, and help you understand when and why it's time to seek medical care. Why are we doing this? Because informed choices on your part today can help you live a better life tomorrow. In today's episode, we will be discussing an extremely common condition, a common condition called gastroesophageal reflux, or GERD. So the GERD, gastroesophageal reflux. Now, this is one of the most challenging conditions because almost every human being experiences gastroesophageal reflux. So let's start with some basic anatomy. We all know where our mouth is. We know where the esophagus is. The esophagus is essentially a hollow tube. So when we eat food and we swallow, the food goes down the esophagus into the stomach. Now, the way we are designed is that a portion of our esophagus is below our diaphragm. The diaphragm, as we all know, is that muscle that separates our chest or our thorax from our abdomen. And there are different pressures. So in order for us to breathe in air, we generate a negative pressure and air goes into our chest. Now, because a portion of the esophagus is usually below the diaphragm, that experiences a different pressure than the pressure in the esophagus that's in the chest. And so that mechanism usually prevents the stomach contents from refluxing or washing back up into our esophagus. But almost every human being has experienced reflux, where we get this bitter taste or acid taste in our mouth. And that's because the stomach contents has come back up for one reason or the other. So everybody has gastroesophageal reflux, but gastroesophageal reflux becomes a disease when it causes problems. Now, what makes it difficult also is that not everyone who is having medically significant reflux damages the stomach or the esophagus. So gastroesophageal reflux, we feel it is called heartburn, but it's that burning sensation in the chest. And in Guyana and the Caribbean, reflux is extremely common, and we all tend to ignore it. Oh, I have gas. Oh, I have acid. But this is a situation where the acid in your stomach or the food contents is washing back up into the esophagus. So it's happening. What causes gastroesophageal reflux to become a disease or a problem? It is when the reflux is occurring more often than usual, and the reflux could actually be causing injury. So what makes it also difficult to diagnose is that even when we take a camera and we look into the esophagus, there are persons who are having significant symptoms and we see no changes, meaning we're not seeing damage or evidence of damage to the lower portion of the esophagus. And so the diagnosis remains tricky. So many times the tests which we are looking to check the pressures in your esophagus, we don't do that all the time, and we can't because it's a risk-benefit issue. So most cases aren't immediately dangerous. Now, if you leave gastroesophageal reflux untreated for many years, it can lead to a damage of the esophagus. It can lead to ulcers. It can lead to a narrowing of the esophagus. So all of a sudden the food isn't going through. And in a worst case scenario, in a very, very small minority of persons, persistent reflux can lead to changes in the esophagus and can become a cancer. Now, come back to what causes it. You need to think of this as a simple plumbing issue. We've got our mouth, we've got the esophagus, which is essentially a hollow tube, and we have got this pressure muscle mechanism that acts as a valve that is supposed to be pretty much a one-way valve, that the food must go from the esophagus into the stomach and rarely go back up. Now, so we've got a tube and we've got a stomach, which is a reservoir, and the stomach usually empties into the little intestine. Now, you could imagine if this reservoir called the stomach, you eat a very large meal, so it gets distended. Or you eat foods that are going to take a little longer for the stomach to empty. So you take fatty foods, fried foods, spicy foods. Those foods are going to take a little longer. So if you're sitting up like this or standing, gravity is helping you. But if all of a sudden you go and have a big meal and then you go lie down, well, what are you doing? Just think about what you're doing. You're just making it easier. Now, there are chemicals which can make this reflux easier. Alcohol, coffee. Well, not just coffee, but any drink that has caffeine in it. So think of, in Guyana, we tend to think that, oh, we can have tea and the coffee is bad and tea is good, but they both contain caffeine. So you think of all your caffeine beverages, tea, coffee, and aerated beverages. Okay. Obesity. So if you think about this, this is, I mentioned, a pressure phenomenon. If you have a lot of pressure on the abdomen, you're pushing things up, and that's going to increase your chances of reflux. Smoking again. This is a recurring theme. You see smoking showing up on almost everything we do. Now, why is gastroesophageal reflux so common in the Caribbean? Well, just think about how our lives are, right? Most of us go home and we end up sitting down, we ingest or we consume a very large meal at night. We have fried foods, we have alcohol, and we're not standing, we're not sitting at the table. Many of us recline soon after we've eaten. Some of us, because of how our lives are, we don't have a lot of time to remain sitting up. My patients always laugh at me when I say this guideline that I want you to sit up for 3 hours after you've eaten dinner. That's nice to want, but it's unrealistic for many persons because the time they get home and the time they've got to get to bed and get ready to go to work, it's just challenging. But what we want you to do is have as much time between when you're eating and when you're lying down. And again, if you could eat smaller meals, that would be helpful. So in the Caribbean, we tend to have relatively large meals, and especially at dinner time, and we need to work on changing that. Now, what are the most common symptoms of reflux? And again, if you think about it, here is the stomach acids and the food washing back up to the esophagus, which is not designed to really handle acids. So you get a burning feeling in the chest, which we all call heartburn. Now, if that reflux comes all the way up into your mouth, you will get a sourness or a bitter taste. You're burping, you're bloated, you're having chest discomfort. Now, and these symptoms all get worse when you're lying down. Now, what we have learned also is that this reflux can be so significant, and people could have what's called silent reflux. So people who have some lung problems, some breathing problems, may be related to their reflux. Some people who are having damage to their teeth could be related to their reflux. Certain asthma symptoms. So we have learned that reflux can cause a broader category of issues, and so you need to chat with your doc. Now, what are some of the symptoms that we never want you to ignore because they're serious? If you're having difficulty or pain when you're swallowing, just think about it. Swallowing is a reflux. We chew food, we swallow, it goes its merry way, and many times we're never thinking about it. If you have to focus on swallowing, if you're having difficulty, if you're having pain when you're swallowing, that's unusual. If you feel that the food is getting stuck, why all of a sudden I'm swallowing and it feels like I have to drink something or I got to do something different to get this food to go into my stomach. Chronic cough or hoarseness, and this is one of the things we've learned. So imagine you're eating, you go to bed, you're lying down, and you're having this reflux. Where is it going? This acid contents are coming back up into your throat, and you're swallowing it, or it's going into the wrong passage. So if you have these issues where you have a chronic cough, that's it. Weight loss. If you have reflux to the point where it's causing ulcerations of the esophagus, it's damaging the esophagus, or worst case scenario is causing a cancer, you're going to bleed. You're going to lose weight because you're not eating like you used to. So unexplained weight loss. Vomiting blood. Anytime you're vomiting blood, there's nothing normal. It's never normal to vomit blood. And you should be chatting with your physician. If you're passing dark stool, again, as fresh blood passes through the entire intestinal tract, it changes. And when it passes out into the stool, it causes the stool to look very dark. Now, do we confuse GERD with other conditions? Of course. So sometimes people confuse GERD with heart conditions. They confuse GERD with ulcers, which we have discussed in other programs. They confuse GERD sometimes with asthma. But your physician needs to check and determine, because these can be all contributing. So when you have chest pain, especially in an older person, the first thing we want to think about is heart disease. Do not think your chest pain is GERD unless your physician has had an examination of you and your physician has checked. Many times people ask, can GERD cause asthma or can GERD cause a cough? And the answer is yes. Acid reflux, this fluid that's washing back up, can go into the lungs and irritate the throat and irritate the airways, leading to a chronic cough, leading to wheezing, leading to changes in your voice. So not only are we looking for heartburn, we're looking to see if you have any of these other symptoms. Now, how is GERD diagnosed? And this is where it gets tricky, because the simplest procedure which we will recommend, and it is a procedure, is called an endoscopy. And this is a procedure where you fast overnight, you come in the morning, your doctor will sedate you. It's an outpatient procedure. We pass a tiny camera, it's about the size of my finger. You're asleep, down the mouth, down the esophagus, into the stomach, and out into the duodenum. So it's an upper endoscopy. So it's looking at mouth, esophagus, all the parts of the stomach, and the first part of the little intestine called the duodenum. Now, one of the challenges with GERD is that not everyone who is experiencing symptoms and not everyone who has medically significant GERD will have erosions. So there are many times an endoscopy is done, but we don't see signs of erosion, but the person is still having significant reflux. And in those cases, there are advanced techniques we can use, such as measuring pressures, checking the acidity levels in the distal esophagus, but those are relatively invasive procedures. It requires you to wear a device through your nose, and most of us are not happy with that. So what will happen in the vast majority of cases is that your doctor will decide, should we just treat you, and what are those treatments? Should we just treat you first, see if something happens, or see if you feel improvement? So we talk about, again, lifestyle changes. And as always, the lifestyle changes are for you to quit smoking and reduce your alcohol. Now, how else are we treating this? So, as we mentioned, this is acid in the stomach refluxing out. So antacids, which are basically a buffer. It's usually some kind of carbonate to neutralize the acid in your stomach. There are certain foods that you may eat, and you are the best person at figuring out what are the foods that you are eating that are triggering these symptoms. And we want you to avoid those. There are times when persons get put on acid-reducing medications. Now, in rare cases, as I've discussed, because this issue is related to the portion of the esophagus that is below the diaphragm, there are persons who they have a challenge there in just how the anatomy is, and they don't have enough or the adequate portions of the esophagus below the diaphragm, and there are surgical procedures that have been designed and are done in Guyana and the Caribbean to sort of recreate this valve or recreate the pressure phenomenon such that the stomach contents don't wash back up. So treatment guidelines, lifestyle changes, acid and acid-reducing medications, antacids, avoidance of the trigger foods, quit tobacco, reduce the alcohol. Now, what can you do to help yourself? Okay? So this comes back to what I spoke about between about the time between when you consume a meal and you're lying down. Ideally, we want that to be between 2 and 3 hours. And yes, we're aware that's difficult, okay? So one thing you can add to that is what you eat and how much you're having for this dinner meal. So you're gonna have dinner and you're gonna go to bed. So do you need a larger meal? Should you eat that larger meal earlier in the day? So eating more smaller meals. Yes, we all need a certain amount of calories in the day, but should we spread that calories out over more smaller meals rather than 3 large meals, but especially the dinner meal? Again, reducing the foods that are going to take the stomach a long time to work on and empty. So reduce fried foods, reduce fatty foods. Caffeine, again, because the caffeine is known to cause this reflux it makes it easier for it to reflux. No alcohol as possible. Now, in certain persons, we actually have to elevate. You will see that persons buy little blocks and they will place it under the head part of the bed to lift the bed up so they're sleeping at an angle. Wait, if you are obese, you're having pressure that is going to make it easier to have reflux. Okay, so smaller meals, try to see at least 2 to 3 hours between eating your last meal and bedtime. Reduction in the caffeine, reduction in the alcohol. If that's not helping, sometimes you have to sleep on higher pillows or elevate the whole head of the bed. Watch your weight. Okay? Now, so what are some of the home remedies we can try? Okay? Some home remedies may ease the symptoms, but they don't fix the underlying problem. So one of the things we want persons to do is try all of that, because many of these things that we just spoke about are over the counter. You can go and get antacids, you can go and get acid-lowering medications. But you should still have a conversation with your physician because the underlying problem, which is the reflux, is not being fixed. You are basically treating the symptoms and you need to get the opinion of your physician. Now, what happens if we ignore gastroesophageal reflux disease? So here is this reflux, this acid continuously washing back up into the lower portion of the esophagus. And that leads to chronic inflammation. You get ulcers, you get narrowing, and you get an increased risk of esophageal cancer. What we have noticed actually is that over a period of years, the cancers of the stomach have changed in terms of their location, and reflux is contributing to the increase in certain types of cancers of the esophagus and stomach, and changes on other types or other parts of the esophagus and stomach that used to get cancers. So please do not ignore this. Now, when should you see your doctor? If you are having reflux symptoms more than a few times a week, if these reflux symptoms are disturbing your sleep, if these reflux symptoms are not improving with the simple over-the-counter medications you're finding, the persistence of these symptoms means it's time to see your doctor, okay? Now, what are some of the key messages we want you all to consider? In the Caribbean, anything to do with the stomach, anything to do with heartburn, oh, it's gas, it's acid, I should just do this, I should just do that. And we generally ignore it, or we feel we can manage this. Please seek the help of your physician because, as we've mentioned, you could just be treating the symptoms, but you're not fixing the underlying problem. So understand, you do not need to live with constant burning or constant discomfort. You can speak to your physician and there are multiple options. And yes, there are even surgical options. And this is well studied, it is well researched, and so your doctor will advise you on what are all of the options that are best for you. And on that note, this brings us to an end of this episode of Ignite Health in partnership with Caribbean Surgery. If there's one thing we would like you to remember, it's that early attention to your health can make all of the difference. You have symptoms, you have concerns, please do not ignore them. Seek the assistance of a qualified medical profession. I am your host, Dr. Surendra Prasad, the Medical Director of Caribbean Surgery, and thank you for joining us on this episode. And please stay informed.
Has there been a change in your income, contact information, marital status, or address since applying to the Ministry of Housing and Water Central Housing and Planning Authority? Then you are required to do an update. Avoid the long lines and crowds. Visit our website at chpa.gov.gy. Click on the Application Update tab and make the necessary update. Utilize our online services. A message from the Ministry of Housing and Water, Central Housing and Planning Authority. Squatting is illegal and poses serious health and safety risks to individuals and communities. The Ministry of Housing and Water continues to provide affordable housing solutions and urges all to follow the proper channels to acquire land and avoid illegal occupancy. If you or someone you know is squatting, contact the Community Development Department for assistance on 227-4164 or 227-4168 or visit chpa.gov.gy to submit an online inquiry using the Contact Us tab. Let's work together to build safe communities. A message from the Ministry of Housing and Water, Central Housing and Planning Authority.